What we're going to do now is I'd first like to introduce two of my surgical colleagues. It's an honor to be able to have them on the stage with us as well. Dr. William Cirocco is a professor of clinical surgery and also the program director of the colorectal surgery residency at The Ohio State University. He's a member at large of the American Society of Colon and Rectal Surgeons Executive Council, and also sits on the editorial board of the Journal of Diseases of the Colon and Rectum. He is a founding member of the American Society of Colon and Rectal Society IBD community, and so we're very thrilled that he could join us on our panel today. We also have Dr. Syed Husain, who is an assistant professor of surgery at The Ohio State University, and also completed his fellowship and training of minimally invasive surgery at the University of Rochester, and followed by a fellowship in colorectal surgery at Brown University. His clinical interest includes evaluation and application of new surgical techniques and technology in the field of colorectal surgery, and specifically minimally invasive platform for the treatment of inflammatory bowel disease. So thank you both for joining us on the panel this afternoon as well. So this is an exciting opportunity for us to really have 3 gastroenterologists, 3 surgeons, and a boxing match. No. So it's going to be an opportunity for us to discuss real-world cases. Use your ARS and start sending me some good questions. I have a couple of cases that we'll be discussing as well, but I want this to be as interactive as possible. Rarely do we have an opportunity where we're all sitting up on stage and in the J-pouch formation right here to be able to present and discuss, right? So keep sending these questions. Let's make this as interactive as possible. We have about 40 minutes to have this panel, so I really want us to be as engaged and interactive. Throw out some case examples you may have, and so in the meantime, as you're being interactive on your iPad, I will just go ahead and start. We'll divide it up. I'll direct it directly towards you guys, and or you just pitch in. There's microphones on the table. So to begin with, skin tag and Crohn's disease, leave it alone or move it? From a surgical standpoint, Dr. Cirocco, do we leave these alone, or what do we do with these?
Leave it alone.
Okay. Dr. Lee?
Oh, I say leave it alone, but the patients are always, I really want this taken off. Why can't you just take it off? You said it's not malignant, but it bothers me.
What's our reason? Why do we leave it alone?
I usually tell them the surgeons told me no.
Okay. That's my excuse always as well.
So
Dr. Husain, why do we leave it alone?
Patients who have, excuse me for my voice, I'll try to be speak as much as I can. I'm sorry about that. So patients who have significant inflammation in the perianal region, it becomes, thank you so much. It's after the surgery, we turn a smaller problem, which looks like it's, for the patient, it's a bigger problem at that time. Having a skin tag, we can turn it into a non-healing wound. And that can be, patients don't realize at the time when they're seen by the gastroenterologist's office, they don't realize how much of a problem it can turn into if we remove that skin tag. So although on the surface it appears like a small problem, it can turn into a much bigger problem. So the only exception to that would be in patients who have those large elephantine, elephantier skin tags, and their perianal disease is completely controlled. They have absolutely no inflammation in the perianal area. In those cases, I sometimes consider removing those skin tags. Outside of that, the general answer would be no.
Yeah. I agree. I think oftentimes it's the patients wanting them removed, but I think it's going to be important for us as their doctors to be able to explain why we don't want to remove them and what additional problems that can cause. So typically leave them alone. So not just skin tags, but then also hemorrhoids. Typically I advise that we leave those alone. Differences in opinion there, or is that the same? Skin tags, hemorrhoids, Dr. Remzi?
It's pretty much the same.
Yeah.
Actually, there is it's the old data, but still it's the data. It's a French group. There's close to 60 to 70% of patients with the active perineal disease gets the hemorrhoidectomy. They lose their anus, so they ended up with a permanent back in these settings. So I strongly discourage them.
Okay. Can we remove a rectal cuff that was placed previously? There's a rectal cuff, recurrent cuffitis, let's say, it's causing some problems. Should we remove it? Can we remove it?
So if it's symptomatic and it didn't respond to medical therapy under the gastroenterologist leadership, the answer is yes. So those are the patients, it's unintentional leftover rectal cuff after a J-pouch procedure. This is what we were talking about, that we can get in there, either do a redo anastomosis or restaple it and leave the area that needs to be left behind 1 to 1.5 centimeter. So or if it's not feasible, you may have to excise the mucosa and do a hand-sewn redo J-pouch anastomosis. But these are big surgeries. They may need a 2 to 3 stage procedure again. Yes, it can be done with the success rates over 85%.
Okay. J-pouch has been formed, patient is doing well, but then post-surgery now develops pouchitis. A few months later, another episode of pouchitis. Now, let's say they've had at least 6 or 7 courses of pouchitis. Dr. Feagan, how do we deal with recurrent pouchitis in a patient medically?
We do badly. I think the vast majority of patients with pouchitis are responsive to antibiotics and do well. The ones that don't, that have become antibiotic dependent or resistant, that is a huge problem. And we find ourselves going back and going, nothing's more frustrating to the patient than being told, oh, you have this immune disease now, but I thought I had the surgery to get rid of that, and now I'm treating you with the same drugs as before.
Do you have a preference over one drug or another in recurrent pouchitis?
We've been using a lot of vedolizumab in that situation, and we think it's a good choice.
For recurrent pouchitis?
Yes.
Dr. Ullman?
Yeah, so I agree with everything that Brian just said, particularly with the greater focus on vedolizumab. I wonder if we have self-selected our patients who, it is so hard to find someone who goes to colectomy who hasn't already been exposed and or failed, and we'll put that in bunny ear quotes, who's already failed an anti-TNF. So, but I agree. Vedo seems to be an excellent choice for those patients. But even then, it's kind of frustrating, and sometimes it becomes, a great weird journey to try and get those patients well treated without having to refer back to the surgeon.
Dr. Remzi?
So just a quick point. One of those things I always tell the fellows, whenever you get a question, you always start, it depends, so it makes you look smarter and everything when at the exam.
But you also have to do this, too.
Just makes it seem like...
So the critical thing is, it's an excellent question, because I think it depends on whether it's a true pouchitis, as my colleagues emphasize, because those are really tough to manage, because that's the diseases being back. But checking the surgeon's footsteps is so critical. When did the pouchitis started? Did it started like right after the surgery? I never felt right, Dr. Remzi. Those are not pouchitis. That's us. That's a surgical complication hinting itself as a secondary pouchitis. I think that needs to be separated.
Okay. So what would you do in that situation?
I would just like to raise that brings a really important point that I think would be of value to the whole community of us here, which is that there really is no substitute for carefully reading operative notes and performing scopes and just taking a direct look and trying to see what's wrong. Too often we get burned when we presume that there's something present when it really isn't present, and whether that's mucosal healing or it's opposite of mucosal activity. You really have to define where the problem is, do a careful pouchoscopy, and define exactly what you see when you do it.
And as we discussed a few minutes ago, it can be sometimes very difficult to differentiate rectal cuff inflammation from a true pouchitis. And I think what Dr. Remzi just said, I think it gives us a very good indication. If the patient has never been, they've never truly recovered after their J-pouch operation, it's possible that they have a larger rectal cuff which remains symptomatic after the operation, and then they present with symptoms that are very, very similar to that, as opposed to somebody who had a great few years after the operation and now are developing recurrent symptoms. So again, endoscopy a lot of times can tell us the difference between a true pouchitis versus just residual rectal cuff inflammation.
Dr. Cirocco, you were saying something?
We had Bo Shannon maybe about 6 months ago, and he's convinced that this is an ischemic event. What do y'all think about that? So we had a discussion, J versus S, and S has less tension when those are constructed, but anyway.
So, the little pearl I have is instead of saying it depends, I say, well, maybe, maybe. And until somebody shows me a series of pouch excision, histology,
So
and if there is ischemic or there isn't, I don't. I just think it's. I suspect that it's mostly a perpetuation of the same chronic inflammatory background with an element of dysbiosis, and as there's sort of colonization or becoming colon-like of the contents of the bacteria that are there, and everything else that goes with that, that there's this reaction into the J pouch. It's kind of ileal mucosa, but not really, not serving really an ileal purpose anymore.
When do you start thinking Crohn's?
I start thinking Crohn's when there are when there are ulcers or changes above in the inlet and above, and when that happens, and there's pouchitis, and I've been trying to sell this on Bo and others, and so I'll sell it here as well. That's a condition called crouchitis. It's not Crohn's. It's not pouchitis. It's crouchitis.
The other thing, I'm not a surgeon, but correct me, if you're doing a J pouch or S pouch or W pouch for cancer, pouchitis is a rare event, right? And so why would we expect more ischemic problems?
So FAP.
Right.
FAP. So we wouldn't normally do pouch.
Use a microphone.
No,
Oh,
no,
sorry.
I mean, so FAP.
FAP.
Right.
Yeah.
You should get the same ischemia afterwards.
Right. And
Correct.
you would think
That's a good point.
you get
So
pouchitis.
I think we can just
So,
say
so the
both-
question there, just to repeat it, the question Dr. Lee was asking is, we do J pouch formation for other diseases or conditions such as FAP. Why do we not see, or do we see the same level of ischemia there? And then you were going to say, Dr. Remzi?
So one thing I was going to add on these patients, you kindly ask what other tests that we work up these patients with the pouchitis. I agree, Dr. Ullman is just pouchoscopy. I complement that also with the exam under anesthesia to look for a sinus, for a leak, complemented with an MRI of the pelvis
Right.
to be read by a specialized radiologist
Right.
and a gastrograph and enema.
Right.
So those are the things. But I mean, we can just move on and just say Bo is wrong. I do believe he's very wrong on this thing.
Bo is typically wrong. Bo don't know. No, I'm kidding. Joking.
Or we can say he's
No,
very
we love
wrong.
Bo.
Because,
Yeah.
but
No.
they're correct.
Yeah.
FAP patients, they do not get this type of pouchitis. Now, one thing that he's right is the patients, they gain too much weight. Like anything else, gaining weight is not good on
Scott, did you
normal
hear that?
patients, but also it's not also good on pouch patients.
Right,
You know,
right, right.
So that's the time that the patients get more bowel habits and everything may be attributed to
Right.
ischemia or everything. But I think that's pushing the limit a little bit,
What about the use, so we'll summarize this whole pouch thing in a moment, but use of probiotics, and this is why I'm looking at Brian here, he loves them. Use of probiotics for recurrent pouchitis. We have VSL number 3 that markets as for those with recurrent pouchitis. Yes, no?
It depends.
Okay.
I learned something. And actually,
Maybe, right?
Actually, the medical equivalent of it depends is the microbiome. Really, the studies that were done in pouchitis with VSL3, they were done in northern Italy, which has also brought us Mongerson and Epinova.
That is the question we'll talk
we've
about.
never been able to replicate those results in clinical practice.
Okay.
I've given people millions of doses of VSL3. I don't think it does
You're
much.
not getting much
At
help.
least in the U.S. I don't know about Northern Italy.
The Italians. Yeah. Okay.
And there was an Ohio-based Bo Shen. Let's give Bo his props. There was a study that Bo did where he could not replicate those Italian data at the Cleveland Clinic.
I was a co-author.
and Dr.
Yeah,
Remzi
yeah.
as well, which is why I was looking.
Remzi just didn't want to quote himself, but there you go. So probably may or may not work. Seems like it doesn't work for the patients that we have. I think the biggest learning lesson here is we need to understand, evaluate endoscopically, cross-sectional imaging, laboratory studies, et cetera, to see if this is truly pouchitis or are we having upstream disease involvement to suggest that this is Crohn's disease and we need to diagnose and treat and manage the Crohn's.
This is really a passion because, you know, our gastroenterology colleagues, they really get stuck with this dilemma. Pouchitis slash, what did you call it? Crouchitis. And it is really checking the footsteps of the surgeon is so critical that if somebody had, as what I said, did great a year or two, then the issues start, that's more Crohn's. But if the issues really started from the get-go with the post-op complications, because honestly, these patients get labeled as Crohn's and sent back to their gastroenterologist, hey, I'm done, it's not surgical anymore, where then the surgical issue started being retreated with biologics again. So 80% of the patients who was sent to us, it's a paper that I did with Bo in the past, we were able to salvage their pouches and redid another one because it was a mechanical issue.
It was a mechanical issue, and so surgical intervention was more appropriate than adding on medications. Okay, all right. Which Crohn's patients would you consider, if any, for J-pouch? Any particular Crohn's patients where you may consider a J-pouch?
So let me be clear. So minimal perianal disease, which means one fistula, and no small bowel or a mild small bowel disease that is interpreted as a backwash ileitis. So these are the ones. In these settings, I'm more liberal about doing a mucosectomy, but I want to be transparent about that. I have done on 15 patients, including the last part of the disease where the pouch was excised, came back as a granuloma redo pouch. These patients couldn't live with a permanent ileostomy. I mean, sometimes as surgeons would just say, live with an ileostomy. I mean, this is suicidal patients, they just couldn't. So I'm not trying to sell this thing as a come to me, I can do a J-pouch as Crohn's. I'm very passionate about this thing. This needs to be very, very selective and responsible. 15 patients, 2 lost, 13 on the biologics are doing okay so far, 2 to 4 years out.
Okay.
So it can be pushed very selectively. I wouldn't do it on a patient with a multiple fistulas, jejunal ileitis. Of course not. A patient like one time distal part is the small bowel, no other small bowel disease, one fistula, not cancrenous ulceration all over the perineum, can be considered. Those patients will not be considered.
Feza, you mentioned backwash ileitis. I have my own thoughts on backwash ileitis. Dr. Ullman, what are your thoughts on backwash ileitis?
So it's a term from the 1960s from the barium enema era. And it's just, I don't know why it still exists, right? So inflammation in the terminal ileum in a patient with colitis where it's only a few centimeters. You know, we used to call that backwash ileitis and back in the days when we did barium enemas. You know, now we don't do barium enemas anymore. So I'm
what are you calling
not sure.
it?
You know, it depends on the clinical scenario. But if that's all they have, that will not. I will not change their diagnosis from ulcerative colitis to Crohn's disease based on that.
Scott, Dr. Lee, would you change the diagnosis from ulcerative colitis to Crohn's disease if you have inflammation in the terminal
If I wanted to get a
ileum?
medication approved for Crohn's, sure. Would I absolutely be hesitant to talk to our surgeons about J-pouch? No, but there's been a few abstracts that say if you have backwash ileitis, your outcome from a J-pouch is not as good. And if we send someone there, I think, as Feza has said, we probably are going to leave them on medication throughout all of this. And that group is usually, they have a dysplastic lesion or something like that, and there's really no choice. So, but I personally am not a big believer in backwash ileitis, sort of like the whole Dalm term. Why are we still? I don't get it.
Okay. So let's do some chromo discussions. one question is, which dye do you use for chromoendoscopy? Usually, I think we like to use methylene blue, indigo carmine if there's a shortage. I don't know if there's any additional thoughts.
That's right. And you can use either. I mean, whatever,
Yeah.
if your endoscopy suite keeps indigo carmine, you can use that. And I've done that during times of methylene blue shortages. But, I sort of learned on methylene blue, and so that's what I used.
When would you refer someone for chromoendoscopy for a provider who does chromo? Meaning they themselves, the endoscopist gastroenterologist, does not do chromoendoscopy. When would you refer someone to someone who does chromoendoscopy?
So the referrals I get, and I got one yesterday, in fact, patients who have a lot of pseudopolyps sometimes end up getting referred to me because the gastroenterologist or the endoscopist isn't comfortable excluding the presence of dysplastic polyps in a sea of pseudopolyps.
Are you comfortable with excluding?
No, a sea of pseudopolyps, I'm like never comfortable
Right.
under any
Okay.
circumstance. In terms of the effectiveness of my ability to exclude dysplasia. Patients who have non-targeted biopsies and the endoscopist swears there was no lesion present, that's oftentimes a referral for a chromoendoscopic procedure to come my way. Those are, and indefinite for dysplasias, are patients who have readings that are indefinite for dysplasia. One of the things I forgot to mention that's probably worth mentioning at this time is that when there is an abnormal histopathologic result, it needs to be confirmed by an expert. And even with low rates of observer agreement among experts, as I mentioned, it's always good to have an expert's eyes take a look.
Yeah. Eric, why don't we have that first case, and this is related to dysplasia, and there'll be a good little discussion among us. So this is a 28-year-old with Crohn's with ileal and patchy colonic involvement for 10 years. Found to have dysplasia on chromoendoscopy in the cecum. Disease is in endoscopic remission. The visible lesion was removed at colonoscopy, but some adjacent random biopsies were that appeared normal also shows low-grade dysplasia. The remainder of the exam is without dysplasia. So what would you do for this patient? And we could have a little reminder. We just want to show off our technology here. Eric's going to show you where the cecum's at, but we just like to show it off. But in the meantime, while he's bringing that up, this patient, Dr. Ullman, we'll start with you. What would you do for this patient who, in Crohn's, ileal and patchy colonic involvement, and now has a dysplastic lesion in the cecum?
So, and the great news is, if we can call it great news, is that the dysplasia was in the cecum. And so, it's much easier to know the cecum than, say, call it transverse colon when there's no India ink that's there. So in the absence of a tattoo, I feel as though I can locate that area pretty well, and I'm going to, chromo the crap out of it. Meaning that I'm just going to take my time and look all around and see if I can see any residual dysplasia at all. And it seems as though there was some residual dysplasia. And, cecum's a great place for flat lesions in general. The whole right side of the colon is, and so I'm just going to spend my time in the cecum with my chromo bottle and try and locate and remove any dysplasia that's there. And probably I'm going to do some non-targeted biopsies when I'm done with that first part to see, as a check to see if I missed anything. And if I did miss anything, then I'm going to send the patient for surgery. And the surgeon, the patient, and I will discuss what surgery at that later date.
Scott, any different
I agree.
approach?
I would repeat it, but
How soon would you repeat this? Just had a
for low
colonoscopy?
grade, probably 6 months.
Okay.
I tend to follow a lot of low grade, but I think in this situation, I would talk to our friendly neighborhood surgeon and say, would you be willing to do a segmental resection here? If I really tried a couple of times and said, I keep getting low grade dysplasia here, I'm not sure where it is. It's non-targeted biopsies. We've done that in a few patients where we can kind of delineate exactly where it is and tattoo it. So we say beyond this area, there's no dysplasia, and they've done fine. One guy had a cancer on the surgical specimen, the other guy had high grade, but they both have ileal to transverse colonic anastomosis and are doing fine. They have to stay on medication, obviously, so you stay on your biologic.
The Crohn's. Right. Bill, would you, in this patient, Crohn's, ileal, patchy colonic involvement, endoscopic remission, let's say they're on appropriate therapy, segmental resection, would you consider that for this patient, or would you consider a total colectomy?
So, yeah, I would say to Scott, you're sending for ileocolectomy,
Yes.
ileocecectomy.
Ileocecectomy.
But is that dysplasia in the cecum, is that a marker for dysplasia elsewhere? What is the rest of the colon last year? And should we diminish the surface area, maybe do an subtotal colectomy, et cetera?
Yeah, I think either way, the issue in the two patients I'm describing, I don't recommend this, by the way, but they literally had very patchy disease, and once I got halfway through the transverse colon, histologically, even on their first endoscopy when they got diagnosed, there's never been colonic involvement downstream of there. And we took, I don't know, 50, 100 biopsies throughout the colon pre-surgical to say we can't find any other dysplasia other than this location. But if the surgeon said, how about a more extensive and their quality of life will be similar, I'm okay with that.
So she's 28 years old, and I think she's got a long ways to go. Her risk of ultimately developing cancer would be much higher than compared to somebody who was, say, 58 years old. I guess the important question in our case, from surgical perspective, would be absence of a lack of rectal or anal disease. And if she has perianal or rectal disease, then it becomes a question, because the surgical options then are either a segmental resection or a total proctocolectomy, which would be maybe a bit too radical of an operation for her. On the other hand, if she has rectal sparing, no history of perianal disease, then the option could be a total colectomy with an ileorectal anastomosis, which would eliminate the rest of the colon. She would still be at risk of potentially developing something in the rectum, but the risk of that would be much lower, and the quality of life with ileorectal anastomosis is actually pretty good. So these would be the two considerations that I would have for this patient.
So she's 28, as you pointed out, and has dysplasia. You're considering maybe surgery. Would you, let's say she says, I'm thinking of family planning in the next few years. Would your surgical options be any different? Would you do any sort of pelvic manipulation at this time, or would you say, let's leave an ostomy? I mean, I don't know, I'm not the surgeon, but what would you think?
So ileorectal anastomosis in itself will probably not affect her risk of fertility as much as a J pouch would.
Correct.
But that being said, it can potentially affect the fertility. I don't think there's any data that looks at specifically at ileorectal anastomosis and the effect on fertility. If she's planning to have children, I think it will be better for her to finish her family, and that
Family
didn't sound
planning.
right,
Yeah.
to go through the childbirth and then come back for surgery afterwards.
Feza, concerns with ileorectal versus J pouch. The J pouch literature that we know, which is an ileoanal anastomosis, we do know that there's an association with infertility as high as up to 40% reported in some studies for infertility risk. Ileorectal anastomosis, I mean, I think it's still some form of pelvic manipulation, but Feza, not sure your thoughts. If let's say she wants to get pregnant.
Sure.
And
So I just want to make one point that I think try to separate this, whether this is Crohn's or UC, is very critical. Because
Crohn's.
in this colonoscopy, what Tom did, and the rectum is completely normal, endoscopically also normal. To me, I concur this is a Crohn's disease.
Okay.
So in that setting, I'm quite all right, contrary to the UC, that area is not diseased with Crohn's, do a segmental, like a subtotal colectomy with the ileorectal anastomosis, and fertility in that setting will be just fine, because we're not getting in the pelvis. The issue is, in the setting on an asymptomatic ulcerative colitis patient, how can you justify decreasing somebody's quality of life with a J-pouch procedure? I still do believe that the risk-benefit ratio, in my opinion, justified, because I gave in that couple times and I failed on the behalf of my patient very badly. That segmental resection in ulcerative colitis setting, where you are leaving a baseline disease behind, reactivates the disease, and it may take the option of a successful J-pouch procedure down the
future.
line
Yeah.
by anastomosis being there and everything.
Okay. Any other?
So just a quick question to the panel and the rest of the audience too. How do you guys feel about dysplasia and setting of IBD as a marker for disease for the entire colon versus a marker for disease for that specific site? I know that that initial data that came out from St. Mark's Hospital actually suggested that it's not that particular location where where the biopsies have shown dysplasia, it's actually its entire colon. So the idea of removing the dysplastic area, do you guys feel comfortable that the rest of the colon is not just it's not a marker for the rest of the colon and the rest of the colon?
So, so the reason that she at 28, can't really see
28.
it from this angle very well, that she at 28 has this at all, is a function of inflammation, almost certainly. And we're presuming there's no family history here. The concept of the field effect in Crohn's colitis and in ulcerative colitis for the development of dysplasia in cancer in there, it's a very real phenomenon. Rates of synchronous cancers and synchronous dysplasias elsewhere in the colon is much higher in patients with Crohn's and UC who go to surgery for cancer. And that's been borne out in the limited literature that's out there for segmental colectomy in patients with Crohn's disease for dysplasia in cancer. They have a very, reasonably high rate to the tune of 40% at 5 years. I think that was the number. And that's a real number. And you have to, you're not going to recommend a segmental colectomy and not talk to this patient about that number. And you'll explain the field effect, and you'll come to an agreement on on what the safest and best thing to do is, based on all sorts of variables that are here. It depends, right? Has she, where is she in her her life's journey as a mom? Maybe she's already had 3 kids and she's done and wants to close the shop. Give her a total proctocolectomy. It's a lengthy discussion.
Bill, would this change if this was a male? I don't think we clarified gender, but would your options change if this was a male patient? Same picture, surgical options, and he says, I recently got married and we are considering family planning.
So it's
No,
not,
Bill, not you.
Yeah, I don't think so. The reason I brought the dysplasia stuff up is, as a surgeon, when we get in the belly, we can tell disease of the small bowel. We can't see through the colon, so we lean on you all to tell us, where's the disease, where does it stop? And that's why I think tattooing is neat, because you can tell me, okay, it's to the mid-transverse, and I got a mark there, and that's where I'm going to resect. So I have no problem with doing segmental resection here.
Okay.
But I just kind of threw that out because, if the rest of the colon looks fine, I think doing something segmental makes sense. I agree with the 28-year-old who, a woman, stay out of the pelvis, less is best, and then go back to your, the ileocectomy or ileocolectomy to transverse makes sense there. But in the male, I wouldn't. The only reason it comes up in the male is if down the road they need the rectum out. That's when we talk about male fertility.
Tom, so let's say this was dysplasia that you felt, same case, cecum, but now you've resected it all endoscopically. Are you worried about a field defect?
Sure. I mean, this is a 28-year-old who, has a dysplastic lesion. I'm hugely worried about cancer in her lifetime, and we're going to have a discussion about the need with our current technology I'm basically going to contract with her that she's going to come back every year for a colonoscopy.
You'd go out a
and
year,
she's not
Tom?
gonna miss- well, no. After it's resected
Yeah.
and clean and the 6-month follow-up is negative,
Okay.
then I'll go to yearly
Okay.
at that point in time. But she's looking at the neighborhood of 70 colonoscopies over the course of her lifetime. if we're not going to do a colectomy. But I am comfortable if I've gotten all the dysplasia. She's at greater risk than a patient who's 28 who has this same IBD history, who's never had dysplasia, but she's by no means a certainty to get cancer.
Feza, what's the risk of mortality with a colectomy versus following the dysplasia that Dr. Ullman wants to potentially follow?
I'm blanking out her name. An article that was
My
written
name?
by a gastroenterologist said the fact that colectomy increases the life expectancy of these patients. I cannot quote that article right now, but there's an article. So I think colectomy in these patients increases the lifespan. I mean, it's not my data, but that's the data that's out there. For the concern what Tom legitimately said, 28 years old, dysplasia already started there, and I agree with you. I wouldn't joke with this. This may be, and because these are the cancers, it can go transmurally that you may not pick it up all the way. It may be too little, too late. Did I answer your question?
The question was mortality. It's going to be very low in a healthy 28-year-old.
Versus older.
Morbidity, however, leaks and such, that's of consequence, but the mortality, I think, would be close to zero.
I have a question.
Yes.
Given the fact that she's so young, and given the uncertainty of pathological evaluation of dysplasia, would it not make a reasonable thing to follow this patient? Because if you were to extrapolate to tuberculous adenomas with dysplasia that you see, many times you remove them and go back and biopsy and they're not there. So would one consider following this patient instead of doing a colectomy, subject this young woman to a colectomy?
So the question is, given her age and given that, given her age, basically, would we not consider potentially just following this patient and surveying and appropriately monitoring and looking for if there is more lesions and whatnot? I think that's what Dr. Ullman's saying in a sense of, let's go in and chromo the heck out of it. I don't know what word he used, but I'm a lady. So chromo it and really evaluate that area, appropriately survey it. And so we would say if you could appropriately survey, and I think it comes down to what is the patient willing to do? Are they willing to come in every 3 to 6 months potentially until you feel that you've completely surveyed and evaluated and there's no target lesions and even your random and targeted are clear? It's going to come down for the very careful discussion. Let's bring the take-home points on this slide. And these were pre-made. There was nothing I knew what you guys all would say. Eric, we don't have it. No, so take-home points is exactly what we talked about. Let's bring our next case. So 29-year-old female on weekly monotherapy adalimumab for 3 years with ileocolonic and perianal disease, now 14 weeks pregnant. Colonoscopy a year ago showed no significant disease activity. She now presents with a new perianal abscess and again, 14 weeks pregnant. She has severe anemia, elevated CRP, elevated fecal calprotectin, and low albumin. What would you recommend for this patient? Dr. Feagan.
Well, I think the first thing is she has active disease by definition now. So there's not much doubt about that. Given she's pregnant, we might want to take a different approach than we would take with a non-pregnant lady, and that could involve ultrasound examination. It could be MR without gadolinium. Probably that's what I would favor. And we need to stage her because, she's putting the baby at risk right now with the disease activity. And the surgeons are going to have to do something with regard to, and I would defer to them with management of her current active perianal problem. But I'm going to have to change her medical therapy, sure. So,
Would you change it right now?
No, I want her staged first. I want to know what we're dealing with.
Okay.
We drained a pus and sent her back.
I knew you guys always do that.
So drain the pus, IND, place a yes, no?
Yes, if there's a fistula,
Okay,
it'll be examined in the OR when she's.
okay.
Do you need the gapless MR if you're going to do an exam under anesthesia anyhow, or are you kind of?
An MR for perirectal abscess.
So the question that Dr. Ullman asked is, do you really need an MR without gadolinium, MRI pelvis without gadolinium? And the reason we say without gadolinium is teratogenic, so we try to avoid that for our pregnant patients.
I'm interested in her small bowel too. I'd like the MR north of the pelvis.
So Dr. Feagan likes north of the pelvis, and so wants a small bowel evaluation as well as the MR pelvis to evaluate for perianal lesions. So I think the answer is yes in that situation to further disease evaluation and for diagnostic purposes. So you place the ceton and antibiotics, no antibiotics, ceton, that's it.
IV antibiotics in the OR, maybe for a few days afterwards.
IV antibiotics in the
Antibiotics and
OR.
maybe a week or so. The main thing is draining the pus. The antibiotics really don't enter in too much.
Okay, be careful with your IV antibiotics and which ones you choose, knowing that she's pregnant, right? So you try to avoid your fluoroquinolones because of the cartilage damage potentially to the fetus or baby. So maybe some antibiotics and then
No
that's-
antibiotics.
No antibiotics? No antibiotics, there you go.
So unless she has larger cellulitis around that area.
Okay,
If it is a well-defined abscess, I would just drain it, leave a ceton, and no antibiotics.
And
If
no
she
antibiotics.
has,
Okay.
an incredible amount of cellulitis, probably use Augmentin for a few days.
okay, and Augmentin is pregnancy safe. Scott,
I just wanted to
Tom?
add, we're probably also, because Adam's not here, I've got to pretend to be Adam. We're certainly going to get all this, albeit this is reactive and not proactive. We're going to get an adalimumab level because that's going to help. We're going to change therapy, but we want to know what to change therapy to.
so I'll play Brian since you're playing Adam. They're already on weekly. I know that I'm just we got each other on weekly monotherapy adalimumab. What do you want levels for?
Well, no. So if she has good levels,
Okay.
right, and no antibodies, then we're not going to put her on. We're not going to put her on infliximab as our next therapy.
Okay.
But if she has antibodies to adalimumab and negligible or no levels rather of adalimumab, then and she's done so well for so long on adalimumab, then we're going to give her infliximab.
Can I play Anita then?
Sure. No one can play
So
Anita.
I like to focus on women's issues. Oh wait, that's so.
Dude, you're not nearly as well dressed.
Are you sure? Come
I'm
on. look at
positive.
This is. She picked this out for me. No. So just to play Anita, devil's advocate, Tom, certolizumab doesn't cross the placenta. Isn't that the way you should go in a pregnant patient?
Yeah, possibly, although, and there is that great advantage in theory to certolizumab here, and I certainly appreciate everything about it, but the data for induction, and this patient is sick, the data for induction on certolizumab is just not as strong as it is for infliximab.
Okay. And so the certolizumab data, because of molecularly how certolizumab is made, it does not have the FC receptor. And so the molecule, because it does not have the FC receptor, it does not bind and cross the placenta and have the placental transfer. And so given that, we feel that since there's no detectable levels through the placenta or cord blood, then we think it's safer to be used potentially in our pregnant patients, knowing that we're trying to avoid the load of the biologic load that's detectable in placental cord blood, which is zero in the use of certolizumab, as opposed to our other biologics where it has higher detectable levels.
Question, Scott. What is the effect of pregnancy on CRP and fecal calprotectin?
What effect does what is the effect is a great question. So what effect does pregnancy have on CRP and fecal calprotectin? And that's a great question. In fact, we've talked about it among colleagues as well. So these labs are so hard to really understand its impacts. I mean, CRP is so nonspecific. Calprotectin, there was just a recent article, but even with calprotectin, what impact it has, it could be still elevated. Low albumin, dilutional, anemia, severe anemia. I think we were trying to say to show that it's really anemia versus, again, delusional as well. So these labs, it's very hard to determine and differentiate how to interpret these labs in a pregnant patient is very difficult. Okay, so abscess, you place the ceton, maybe yes, maybe no antibiotics, but I'm still stuck on monotherapy. Let's make adalimumab, you would just continue it. Let's say drug levels are fair and there's low detectable antibodies. What would you do in this situation? And let's say that there is active inflammation on the
Well,
MRI.
Okay, so if her MRI looks bad.
Yes.
And I've got to do something, and
Okay.
there's this old-fashioned set of drugs called corticosteroids
Okay.
that work real well in this situation.
Okay.
Surgeons have drained the little problem in the pelvis, and so steroids, I'd be temporizing. I'd get my drug level, and then I'd make that decision. If she's got low drug levels and I've got her on steroids, well, I can wait to, give her 80 milligrams booster, and I'm okay. If her drug levels are high, okay, 10, 15, then I've got a bigger issue because you're going to have to decide which, and especially if she's really sick, because then your choice is going to be really, there's not a lot of value in using infliximab in that situation where you've got a drug level of 20 or 30. So you're going to have to choose between USTA and Vedo. And Vedo, it's a category B drug under the old classification.
Right.
I'm not going to learn the new one.
It's been 3 years.
Yeah. So, I think that really comes important decision because Vedo, there is experience and it's a category B drug. USTA is a category B drug as well, but there's not as much experience.
What about a small molecule?
The small
Jack.
molecule, yeah, this is not a case for TOFA. It's a relative contraindication. Well, it's a contraindication pregnancy.
Okay, so steroids, you say let's cool her off with, I don't like using that word when we're talking about severe disease, but sounds like maybe induce her with some corticosteroids, and then the 80 milligrams Dr. Feagan is referring to is dose optimizing 80 milligrams of Humira, not 80 milligrams steroids, just to clarify that. I think that's what you were trying to say, correct? Yeah.
Correct.
Okay. So steroids, corticosteroids, using the old classification, the pregnancy classification A, B, C, D, X. Since 2015, we no longer do that. We say more of women of childbearing age, and there's a new categorization where we now really have to understand the placental transfer in and of itself, but then also the impact on fertility and also the impact in the use of these therapies for male gender as well. So in this patient, steroids, we know if we use the old classification, it is a category D with a higher risk for cleft palate. So definitely in the first trimester, because remember, organogenesis happens in that first trimester. Category D, 14 weeks. So what are we going to do now? You started steroids, still getting sicker and sicker. So
I'm sorry, I have a quick question. You mentioned vedolizumab. What are your thoughts about using Vedo in a patient who already has perianal disease?
When we looked at the clinical trials, there was a numerically increased risk of perianal sepsis in the Vedo group versus placebo.
That's been our experience as well.
Yeah, I think though when we've looked out longer in the larger cohort studies, the open label extension, we haven't confirmed that. So it's a theoretical problem with the drug, but would it influence my decision making? I don't think so in the situation. What's going to drive the decision making here? If she's not settling down with steroids, I'm probably going to use ustekinumab over vedolizumab.
Because of rapidity?
I think, yes.
So didn't Bill with somebody just publish about Vedo post-operatively? Yes,
Yeah,
because
I knew we were going to get into this.
well, the surgeons care.
And Scott, do we really want to start this? We've got 3 surgeons here. We don't even outnumber them. Okay, so I'll give you my thoughts. When you see the same thing happening all the time, you come to recognize it. And this started with infliximab, and not the erudite surgeons that we have here, but some surgeons believe that any drug is bad, okay? And they usually do a study where it shows that sick patients with ulcerative colitis, usually ulcerative colitis initially, and have an increased risk of perioperative complications if they're exposed to infliximab versus other therapies. And there's a couple big problems with those studies. What's the greatest predictor of post-operative complications? You guys see it all the time. It's how sick you are when you're going to the OR. And who gets the biologic drug? Well, it's the patient who's sicker. So it's confounded. And the surgical studies, unfortunately, the way they're done is it's tough to get a measure of disease activity before they go to the OR. So there's a big problem with confounding with those studies. And when people have tried to adjust for disease activity, those rates are not apparent. And so we're seeing exactly the same thing with the Veto studies as those trials, and predict that ustekinumab will also show the same thing.
Feza, would you consider if this, we're going to change this around, a whole different question. If this patient had a J pouch and got pregnant, not perianal disease, take this case away, new case. If this patient had a J pouch and is pregnant, so infertility was not an issue, would you advise them still to have a C-section with the J pouch?
Yes.
Okay, and why is that?
So we have done study at the disease of colorectal many years ago, showed the fact that the quality of life. So we didn't know. So certain patients in those settings used to get vaginal delivery. Some used to get C-section, and we found the fact that the vaginal delivery patients, at the blinded evaluation by the ultrasound and the anal manometry, had worse results. And some of those worse results reflected on one quality of life measurement, but didn't impact the function. This is the thing. I don't want to tell my patients 20 years down the line that I was wrong, that we put them through a vaginal delivery. The other thing, especially for US, not for Canada, that our OBGYN colleagues, they prefer a median episiotomy here. Comparing to Canada and Europe, they do a medial-lateral episiotomy. So that increases this care, getting in right to the pouch and everything. To me, it's an unwarranted risk. Does the C-section have a risk? Yes. I had 2 bad complications. One in someplace in Indiana, the surgeon unintentionally got on the iliac. The other patient in West Virginia, they had a small bowel fistula, but all recovered well. The sphincter is such kind of a precious organ that if it goes one time in a setting of pouch, that's really not a recoverable organ. That's the reason.
Brian, everyone wants to know what happened to Mongerson. I'm just reading the questions here.
Came from northern Italy. I explained that.
Okay.
Well, no, I mean, it was an unequivocal result. I mean, the study had a pre-planned interim analysis based on over 700 patients in the 2 trials, and the point estimates between placebo and Mongerson really were almost the same.
And last question, and we're going to call it a day, and this is specifically for Brian. Why did risankizumab's higher doses look not as good as the lower doses? Why did risankizumab's higher doses?
No, the 600 milligram dose was more effective than the 200 milligram dose.
So it was more
And the
effective.
dose that's being taken forward in trials is 1,200 milligrams.
Okay.
And one thing I'd say that, the newer biologics, the newer monoclonals, almost all the programs are taking both subcutaneous and intravenous drug forward. And that's going to give us a lot of flexibility in terms of dosing. And the other thing is that the IL-23s and to maybe a lesser extent, ustekinumab, are our first drugs where we think we're up on the plateau of the dose response curve. And what we're seeing, the effect of ustekinumab, the low rates of immunogenicity, may in fact just reflect the fact that we're getting high zone tolerance. Giving a lot of drug up front seems to reduce sensitization.
And very last question for the surgeons, how do we distinguish a surgical pouch complication versus Crohn's? The audience we still need to know, how do we know that this is surgery and not Crohn's?
You can't. So we went through the things that the history of those things that we explained about when did the issue start, whether the patient had a peri-pouch complication when it was done surgically or not. Then you do get the gastrograph and enema, MRI, and flexible pouch obstruction exam under anesthesia. In those settings, this is really the exact word by word that I tell to my patients, that I tell them, I may not prove or disprove that you do not have Crohn's disease. But if I prove the fact that they have a mechanical issue, I still offer them the redo. understanding the uncertainty of the Crohn's.
Sure.
So as long as they understand that small possibility that I can never eliminate unless it's a for sure, the presentation 5-6 fistulas all over small bowel disease, they need to understand that uncertainty.
Yeah. Bill, Said, any additional
I had a
comments for that?
question for Feza. So when you do a remedial operation on a pouch, is that an automatic diverting stoma?
So I like the 3-stage step. So if the question is what I understood, patient has a dysfunctional pouch, they're suffering and they're considering the possibility of a redo pouch, I do exactly what you do, timeout. So I give them an ileostomy. And I tell them my agenda is not to do a redo pouch on you. If they are okay to live with an ileostomy,
Okay.
and they're perfectly happy, trying to convince them a redo pouch is a big disservice. But what we need to understand as a surgeon against gastroenterologist, some people cannot. And as long as it is a fair option for them and they're willing to take that, I absolutely recommend them having a redo pouch.
Okay, Said?
So I think it can be very difficult to differentiate between the two conditions. As Dr. Remzi said, I think you have to go into the history of that patient, see if there was any preoperative evidence of Crohn's. So that's number one. Number two, thorough investigations, which include for us examination under anesthesia. And a lot of times, patients who have perianastomotic complications after a J pouch procedure, they can present as a perianal fistula or worse, a rectovaginal fistula. In that case, if the fistula is arising from the anastomotic site and there is no evidence of disease upstream in the proximal pouch, and there was no antecedent history to suggest Crohn's disease, then it's more likely an anastomotic complication compared to somebody who we were not sure if it's Crohn's and indeterminate colitis.
Right. Yes, Bill?
So one last, on that topic, we spent a lot of time talking about pouch complications and multiple reoperations, remedial. So we talked, and then Feza mentioned gold standard. I don't know if we should use those terms. So when a patient has colitis and has the option of a pouch, I don't think we should impose that on the patient. This is what you should do, because I'm a surgeon and it's a great operation, no doubt. It's probably the best thing we do. But we shouldn't impose that. So if the patient has that stoma and is happy with it, and a colitis patients, for once, they're not running the bathroom 10, 20 times a day. And I'm sure you've had patients as well. They're quite happy with that. So I think we kind of, there's sort of leading statements to patients, sort of setup statements, but I think this is a personal decision on where they go as far as having a stoma versus having an option to have a pouch constructed.
Point well taken. Thank you to the panel.